you all for joining us to celebrate the official launch of our social inclusion framework and to share in the very special experience of hearing from our esteemed keynote speaker, Patricia Faulkner, Order of Australia. Before we begin, I would like to acknowledge the Wurundjeri and Bunurong peoples of the Kulin Nation, where I'm based, and also other Indigenous groups on whose unceded lands our gathering takes place. I pay my deep respects to their elders and recognise the impacts of colonisation on First Nations people and the sorrow of the stolen generation. I also recognise and value their knowledge, resilience and ongoing contribution to health and wellbeing of the whole community. I would also like to thank our board for supporting this initiative to happen online and the Department of Health and Human Services for the funding to enable us to support our partners to work together to promote social inclusion and reduce inequity in health outcomes. The InterAce Primary Care Partnership's mission is to be a dynamic organisation that drives transformational positive change to health and wellbeing. One of the ways we achieve this is to contribute to the building of the prevention evidence base and workforce capability of our partners around core health priorities in our catchment. Social inclusion has been a local priority for several years, formally recognised in 2015 by MSIC, the Eastern Metropolitan Social Issues Council, a senior executive leadership forum in the region comprising state and local government departments, non-government organisations, health organisations, academia and industry. MSIC were committed to working to increase integration and alignment of regional efforts to improve community health and wellbeing on key social issues impacting the region. Deakin University was appointed by MSIC to review evidence, activity and potential partnership approaches and make recommendations for future opportunities for action. One recommendation identified capacity building for organisations, particularly in relation to developing the evidence base around social inclusion, and to consider where partnerships with relevant expertise could add value and contribute to developing evidence-informed practice. This was of particular interest to our PCP. In 2017, a group of dedicated health promotion organisations came together in our catchment, interested in collaborating to increase the social inclusion of marginalised populations and agreed to operationalise the recommendations endorsed by MSIC. The InterAce PCP was very proud to be invited to lead what became the InterAce Integrated Health Promotion Partnership and to support capacity building of practitioners working in this space. We recognise the processes that lead to social exclusion are multidimensional, and as such, this was a complex system to tackle. It became evident that a guiding framework would be an important tool to support understanding and practice, and the InterAce PCP set about developing our framework in consultation with partners. MSIC had adopted the definition developed by the Social Inclusion Board, which defines social inclusion as being when people have the resources, opportunities and capabilities they need to learn, work, engage and have a voice. This definition really resonated for us as it captures the multidimensional nature of inclusion, locating the individual within a system of socioeconomic barriers to resources and systemic discrimination from opportunities that need to be addressed in order to overcome exclusion and increase equitable access and participation in community life and decision making. This definition was built into the strategic plan of our partnership and forms the basis for the population health and ecological approach to practice set out in our social inclusion framework. Today, as we proceed to launch our framework to partners, I'm especially delighted to welcome Patricia Faulkner AO, former chair of the Australian Social Inclusion Board, the entity which originally defined the domains of social inclusion that the Unirests have adopted. And we invite her to share with us her role and that of the Social Inclusion Board, and as is so fitting at the end of the forum, to formally launch the Social Inclusion Framework. It's my great privilege now to share a brief snapshot of Patricia's distinguished career dedicated to advancing inclusiveness. Patricia is a chairman and board director with extensive senior and chief executive experience across a range of sectors, including health, welfare, banking, telecommunications, government, superannuation, and professional services. Patricia currently chairs the boards of Jesuit Social Services, the Telecommunications Industry Ombudsman, the CBA's CEO Advisory Panel, and the Melbourne Racing Club Foundation, and is a board member of several others. In 2015 and 16, she served as a Deputy Commissioner to the Victorian Royal Commission into Family Violence. Patricia was a previous Secretary of the Victorian Government's Department of Human Services and held a number of roles within the Victorian Government, including Director of Consumer Affairs and Director of Occupational Health and Safety. Patricia's full bio has numerous previous positions of note and, as mentioned, Chair of the Australian Social Inclusion Board. Patricia was made an Officer of the Order of Australia in 2008 for service to the community through the development and implementation of public policy related to health, aged care, children's services, disability services, and housing. And in 2013, Patricia was recognised with an honorary doctorate from Monash University. Welcome, Patricia.
Thank you very much. And thank you, Tracey, for that extremely generous outline of my career. Thank you. I'd like also to join in your acknowledgement of the traditional owners of the lands on which we're meeting today and pay my respects to their elders past and present and to their emerging leaders. It was certainly a delightful surprise to be approached by Sue recently, a couple of months ago actually, to ask if I would like to participate in the launching of the social inclusion framework that's been developed by the Inner East Primary Care Partnership for use within the health promotion context. In 2008, I was invited by the then Deputy Prime Minister, Julie Gillard, to chair the inaugural Australian Social Inclusion Board. With me on that board were some very eminent and famous Australians. They included Fiona Stanley, who was the Australian of the Year in 2003 and was recognised for her work in epidemiology relating to children's health. There was also another famous person, or someone who became more famous afterwards, Ahmed Fahua, who became famous for being the highest paid Chief Executive Australia Post. However, at that stage, his interest was from his position at the National Australia Bank in micro business financing. Eddie Maguire was there, as was Tony Vinson, who had just published his book, with Jesuit Social Services' help, on the distribution of social disadvantage in Australia. There were some leading welfare luminaries, such as Tony Nicholson from the Brotherhood of St. Lawrence, Dr. Chris Sara, a renowned Indigenous educator, and Dr. John Falzon from the Society of St. Vincent de Paul. In my life, from the years 2008 to 2012, social inclusion and what it was and how to achieve it and how to measure it were a central part of my working life. With the board and with a very small unit in the Prime Minister's Department in Canberra, we set out to define what being socially included meant, and to work out how governments and communities and professionals could counter the very grave effects of exclusion. We wanted to work out how to measure the progress of Australia to a society which included all people. So on a sunny day in 2008, the 13 new members of the Australian Social Inclusion Board joined the newly minted Prime Minister of Australia, Kevin Rudd, and the Deputy Prime Minister, Julia Gillard, who was also the Minister for Social Inclusion at the time, at the Broadmeadows Library, Broadmeadows in Victoria, obviously, to launch its work. When we arrived, we were very delighted at the interest that people had in this launch, and we felt very positive about the fact that the press had that interest. We were soon to discover, however, that their interest was purely in Eddie Maguire, the most famous son of Broadmeadows, and he managed to overshadow both Kevin Rudd and Julia Gillard. And that was probably because the concept of social inclusion was very, very difficult for people to understand. There were so many ways in which people could be socially excluded, through lack of education, through homelessness, poverty, illness, and simply by the place in which you resided. There was also great confusion between how did loneliness compare with exclusion. So we started a search for a simple but comprehensive definition and explanation of what is social inclusion. At the same time, we also saw the emergence of literature relating to the social determinants of health. I had worked, as was pointed out, for the years 2000 to 2007 as the Secretary of the Department of Human Services in Victoria. And at that time, the department had oversight, funding responsibilities, or direct service delivery responsibilities for the Victorian public hospital system, for the community health system, for child protection, juvenile justice, disability services, housing, and homelessness services. And we knew through our work that a person's welfare status was in fact determined by an extremely complex set of factors, including place. The catch cries at that time in our department were about joining up services and the importance of the development of social capital. However, the notion that health outcomes were determined by social factors rather than curative treatments was only slowly emerging. Luckily, most people who came onto the board understood that excluded people's lives were extremely complex. And yet, the treatment systems and the support systems broke people's lives up into pieces and treated people's problems in pieces. Certainly, the Department of Human Services at the time initiated a number of neighbourhood renewal projects, which were recognised as successful when they were finally evaluated, but nevertheless, they disappeared from sight soon after. The treatment systems, as I said, broke people's lives up into pieces. So some families could be being served by up to 6 workers. They might have a drug worker, they might have a homelessness worker, they might have a child protection worker, they might have a family violence worker who was separate. And so we tried very hard to simplify the concept of social inclusion. We came up with a description that's already been mentioned that has found its way into the social inclusion framework that is being launched here today. I'll go back over the definition because it took many hours of work to come up with it and lots of debate. Essentially, we started from what people wanted to be included. They wanted a job or activity or an occupation. They wanted to be educated. They wanted to be engaged with people around them, and they clearly wanted to have a voice. So we came up with learn, work, engage, and have a voice. And we expanded on some of that by saying, well, learning was pretty obvious. You get to participate in education and training, and that might be lifelong education rather than necessarily an episodic view of education. Work was one that was debated a lot. At the time, the prevailing view that work was, and the only sort of work that was valuable, or it seemed to be a prevailing view, was paid employment. But we clearly felt that unpaid employment, voluntary work, and caring responsibilities were part of work. Engaging was connecting with people, using local services, and participating in local cultural and civic and recreational activities. And the focus there was on local, because the work on the importance of place in social inclusion was emerging quite rapidly. And having a voice, I think, has never gone away, but it is often something that is totally ignored. Having these definitions gave us some goals to aim towards. However, we also knew, and it was emphasised greatly to us, that what gets measured gets done. So we embarked on trying to bring together a set of indicators which measured social inclusion. We believed that public focus on published indicators might prompt community interest in social inclusion. Although it was an interesting exercise, it probably, with hindsight, may not have been the best use of our time. Measuring exclusion was extraordinarily complex for the very reasons I described earlier, because we actually had indicators that measured our practice as it was then. So we had measures of parts of people's lives. We'd always aspired to eventually coming up with a clear index of well-being, but to this date, we've not achieved that. We did have measures of parts of people's lives, as I said. We did have measures of poverty, illness, disadvantage, and we published, I think, 2 volumes of those indicators, trying to get people's focus on what inclusion could do to make our society a better place. However, with hindsight and knowing that we didn't survive long enough to do this, I wish we'd put more emphasis on changing practice of how we dealt with exclusion. We needed to recognise, and I think this framework recognises, that we need to understand people in their context and in their system. Certainly Tony Vinson's work in Dropping Off the Edge showed that many different kinds of disadvantage, such as poorer housing, lower educational attainment, poorer social connectedness, community capacity, unemployment and crime rates, tended to coincide for families and individuals in a relatively small number of places. And these concentrations of disadvantage tended to persist over time. So we at Jesuit Social Services have continued to work on Tony Vinson's work. He's unfortunately passed a number of years ago. And we continue to see that those concentrations of disadvantage, sometimes called postcodes of disadvantage, persist. So we therefore have to look at the system's factors to see what is going on and to find solutions. At the time, we also did some work on intergenerational disadvantage, which involved us in meeting with families and people who appeared to us to be socially excluded. They had been parts of families that had been generationally unemployed and in public housing. They actually taught us a great lesson. And that lesson was to listen very well to what people's perspectives were. rather than impose our solutions or aspirations on those people. By doing that, of course, you rob people of agency. They rejected the notion that they were disadvantaged, and they felt sorry for us because they believed they had a level of connectedness that made them happy. As I said, had the Social Inclusion Board's work been given a longer life, we might have got to the point of looking at practice innovations. But what I can say to you is the Australian Social Inclusion Board would have applauded the approaches outlined in the framework that you have before them today. They would have delighted in the case studies to be presented soon. And from my own perspective, a great influencer in my career was a man called David Green, who probably is not known to many of you, but he would see that in the Inner East Primary Care Partnership, we see a rising to the notion that if we are to help people with complex lives, we should have a workforce that can deal with complexity, that can understand the determinants of exclusion and can work at many levels. Yes, with individuals, yes, with groups, with families, maybe better in a community, and certainly at a system level. It is often the understanding of the system which brings solutions. I want to close in thanking the organisers of today's event for including me in it, and express once again my gratitude that the work of the Social Inclusion Board is finding life so much after its demise.
Thank you so much, Patricia. It's a real honour to have you join us today and to hear your in-depth understanding and some of the history around social inclusion progressing, and to realise how much we've all benefited from your enormous contribution to public policy. Thank you also for your generous endorsement of our social inclusion framework. I'm now going to invite Dr Sue Rosenhain, our Manager Integrated Planning, who authored the development of the framework, to discuss how it can support the development of effective and system-level social inclusion strategies and guide us through its content. Then we will hear from local practitioners who will demonstrate how the framework applies to their practice before concluding with the launch. Before I hand over, I'd like to take this opportunity to personally commend Sue on an outstanding comprehensive piece of work. Sue is a passionate advocate for health equity and systems change to improve population health and wellbeing, and we are so fortunate to benefit from her extensive expertise in our organisation and in the region. Thank you, Sue. Please take us through the framework.
Thanks, Tracey, and good morning, everyone. And I was probably blushing a little bit there, but so yes, I'm Sue Rosenhain, and I'm speaking to you here from Wurundjeri lands. I'm in the northeast suburbs of Melbourne, and the land's looking glorious this morning after a nice drop of rain last night. And I too would like to acknowledge the traditional custodians of the land and pay my respects to their elders past, present and emerging. After hearing Patricia speak, I'm even more pleased that we invited her to speak to us and that she was able to come. And the consideration of how we honour the work of people who've gone before us, and the thinking that's gone into, and the time and resources that have gone into thinking about how we can address some of these concerns for social issues that we all have. And I'm really pleased that this framework and the work of the partners in the Inner East and beyond, and I know there's a lot of work happening on addressing social inclusion and building social inclusion across the state and beyond, can continue the work of entities even if they're no longer funded to do it. And I think it's important that we can continue to build on work and learnings from those who spent such a lot of effort and honour their work. So just to note that if you've got any questions so I'm going to take you on an overview of the framework in just a moment, but to note that if you've got any questions for either Patricia or myself, that you can put them in the Q&A, and at the end of when I've gone through the framework, we'll be answering some questions. Probably if you want to hear from Patricia and questions for her, I'll be around a little bit more accessible to most of you afterwards. So we'll prioritise those. And also to note that any of the questions that come up in the Q&A, we'll be doing a written response and sending that to everyone who registered for the session. So you can absolutely ask any questions that you might like. And even if we don't get to answering them today, then we'll get back to you. We'll also like to suggest that if you'd like to talk about application of the framework in your own particular context, that you can email us, leave your email in the Q&A, or email us via our website, and we'll be back in touch. Okay, so I'm just going to share my screen as we start on this, and I'm going to take you on a tour of the framework. So in 2017, as Tracey said, the Inner East Integrated Health Promotion Partnership identified social inclusion as a priority for health promotion action, building on some of the work that had already been established and identified by MSIC in the Inner East. And while social inclusion underpins all health promotion as a matter of equity and social justice, as a specific area of focus, this was a new priority for health promotion, which therefore required the partners to build a shared understanding of how to approach the work. Initially, it was important to decide on the definition of social inclusion that we were going to use to inform our work. As we've heard from Tracey, the group adopted the definition developed by the Australian Social Inclusion Board, as it is consistent with the principles of equity and social justice, and because it directs analysis and planning to consider the environments that enable social inclusion rather than focusing on individuals. And as we've heard from Patricia as well, that was particularly the focus of the board too. And we know that even more so now, having heard her address. The framework has been developed to guide actions that will promote social inclusion and an inclusive society. It includes a definition and expansion of the definition, not a definition, the definition that we've just heard about of social inclusion, an outline of the guiding principles and values that inform the work, a model explaining the factors that make a society inclusive, an explanation of how social inclusion relates to other key concepts such as social connectedness. And interesting to hear from Patricia how that was a consideration of the board, and social connectedness and loneliness is one of the other dimensions that the framework thinks about, how these concepts relate to social inclusion and how we can make sure that work that is being done on other priority actions can complement one another. And we've also got some case studies that demonstrate social inclusion in action. As Tracey and Patricia have already noted, the definition is composed of two key elements. The first element is the identification that social inclusion is when people learn, work, engage, and have a voice. And Patricia's guided us through what all the thinking and consideration was at the time of the development of the definition and why these dimensions were all so important. And this has certainly resonated with us as we've built our work through the Inner East and thinking about what it is that means people can be included. So we've heard that learn means that people participate in education and training and lifelong education as a consideration of that. And interesting that one of the case studies is actually about the development of new University of Third Age opportunity done by some of the Opening Doors graduates. And that absolutely links in with what Patricia was saying, that we think about learning as a lifelong experience. And working that people participate in employment, unpaid or voluntary work, again, really important, that dimension of the definition for us. And another of the case studies is considering how to increase opportunities for volunteer work and the importance of recognising family and carer responsibility. Engaging for people connecting with others, using local services, and again, the emphasis on local cultural, civic and recreational activities, which has been important for us too. And having a voice, as Patricia said, the importance always that people can have an influence on the decisions that affect them. The second element, that people have the resources, opportunities and capabilities they need in order to learn, work, engage and have a voice. And having resources includes having access to transport, adequate income, housing, digital connection, urban design, community facilities and social infrastructure. So if we're thinking about our work, then working towards all of those things, towards being able to learn, work, engage and have a voice, all contribute to building social inclusion. People have opportunities when there's freedom from discrimination, which of course can take many forms, such as race-based discrimination, gender, gender identity, sexuality, age, faith, abilities. So freedom from discrimination of all forms enables people to have the opportunities to learn, work, engage and have a voice. And also when there are options, a variety of means for engaging. Having capability includes a freedom to choose, physical and emotional capacity, self-respect and adequate nutrition from a secure food source. This second component, that people have the resources, opportunities and capabilities they need, is where we can be directed to think about the circumstances in which this can occur. How does our society function to enable this need? Does this occur equally? Do all people have the resources, opportunities and capabilities they need? Or are some people missing out? What is the cause of any inequality? This is where we need to focus our work. The framework is intended to be an instrument to guide this kind of thinking, to assist us with our analysis of the situation in our own context, to support action planning that is within our sphere of influence, which is consistent with looking at societal and systems change, not individual level, to promote evaluation and reflection, and also to encourage conversations between people who are interested and able to contribute to complementary action. The framework uses the socio-ecological model of health as a way of understanding the norms, practices and structures that enable or provide barriers to people having the resources, opportunities and capabilities they need to learn, work, engage and have a voice. And in doing so, it helps us to understand and explore the questions that I was posing previously. So how does our society function to enable this need? The need for people to have the resources, capabilities and opportunities they need to learn, work, engage and have a voice. And does this occur equally, or are some people missing out? Originally, this framework was developed by Bronfenbrenner in the 1970s as a theory, to explain. Now this is where I find the Zoom interesting compared with the seeing you all when I go, oops, here I am in my room by myself going, oops. So I hope you're getting a little laugh at me going, oops. But this is what we don't know in this forum. Anyway, so interestingly, the socio-ecological model developed by Bronfenbrenner in the 1970s is the theory to explain childhood development. This model of health has been used widely in health promotion to inform a determinants approach. And that is to help us understand the social factors that determine or cause the health outcomes that we observe. And one of the other reasons that we chose this theory in the social inclusion framework was because it's also been used by Our Watch as the underpinning theory in Change the Story to explore and communicate work towards prevention of violence against women. And prevention of violence against women and building gender equality are the two, is another key priority of work for the partners in the Inner East. So it was to also build on the momentum that's within the workforce and broader community and of understanding that Change the Story has built. So we wanted to be consistent. And so the model identifies that norms, practices and structures operate at the individual, relationship, community, institution and society levels, operate here to determine social outcomes, health outcomes, such as social inclusion. Social norms are beliefs, values and attitudes. Social practices are the expression of these norms in behaviour and social structures are the formal and informal systems through which we organise our society. Social norms, practices and structures are influenced by, so there's a backwards and forwards relationship here, they're influenced by one another and they influence by and influence one another. For example, in a democratic country, we can enact a law, that is, create a structure, if it reflects enough attitudes of the attitudes of enough of the population. Equally, once a law is in place, people's attitudes, norms and practices will change. So I'm just going to divert from social inclusion for a moment directly, although clearly there have been some learnings about social inclusion of the experiences of our last year. So a recent example of the relationship between norms, practices and structures is the social distancing requirements and mask wearing to limit the spread of coronavirus. Think about how your attitude to wearing a mask may have changed over the last 6 months. To be honest, prior to that time, I didn't even own one or had not particularly used one outside work, moving in a hospital, being in a hospital. And then I actually started to feel a bit naked and if I was going out without one. And I certainly now will keep one on hand for circumstances beyond corona. And as a community, we accepted the law, the structure that came into place requiring us to wear masks, most of us, overwhelmingly most of us, because it reflected good public health evidence. And it made sense to us. Subsequently, this requirement, the structural change to wear the mask and to socially distance, has changed both our practice and behaviour and our attitudes, our norms. For me, and I think for many others in the wider community. So, back to the framework, more specifically, the framework also includes 6 case studies. As the framework is new, there are no case studies demonstrating its use as a planning tool from program outset. What the case studies do illustrate, however, is how the elements of the framework can be applied to contribute to building social inclusion. Some of the examples were in operation in Melbourne's Inner East at the time the framework was being developed and were informed by the thinking. Others are examples of practice that demonstrate the approach despite being implemented independently. For example, one of the case studies describes an approach taken by Eastern volunteers and their partners, including the Inner East Primary Care Partnership, to build the capacities of organisations to provide opportunities for people experiencing disability or mental health issues to volunteer work in their communities. This project identified that organisations engaging volunteers required support and capacity building and encouragement to address the norms and beliefs about who can be a volunteer, how a wide range of people can contribute, and also to put practices and structures in place to enable opportunities for people with disabilities to volunteer. Another of the case studies is the Opening Doors program. Opening Doors runs a 6-month leadership program for grassroots community leaders to support them develop programs that build social inclusion in their community. Since its inception in 2009, Opening Doors has graduated 251 community members who have the passion, network and skills to foster meaningful and lasting social inclusion in their communities. The program has supported the development of more than 160 unique and innovative community initiatives, which have connected with many thousands of other people within their communities in new and positive ways. Many of the elements of the social inclusion framework are demonstrated by the Opening Doors program. Recognising that leadership programs are often out of reach for many grassroots community leaders, that is, there's a structural barrier to both having opportunity and capability. Opening Doors addresses this barrier by providing an opportunity and the resources for community leaders to develop their capacity to engage with others and to build the opportunity and capability for everyone to have a voice. Furthermore, program participants are encouraged to think about the norms and attitudes, practices or structures that provide barriers to engagement for people within their communities and to design their programs to address these barriers. By working with community leaders to initiate programs that change norms, practices and structures within their own spheres of influence, Opening Doors extends its reach far beyond the participants that attend the program, enabling sustained change in many different arenas. There are 4 other case studies one of which we're going to hear from shortly in more detail, but the others focus on addressing the norms that limit opportunities for older women to have a voice. And this is work that's been done by Women's Health East in partnership with Inner East Primary Care Partnership, a program called WASI, Women, Ageing and Social Inclusion. Another case study focuses on building the structures and fostering norms to providing young people with the opportunity to engage and have a voice in their community. And this is work that's been led by the East Gippsland Primary Care Partnership and who've developed the East Gippsland Mental Health and Wellbeing Network. Another is about developing the structures to provide resources and capabilities to support digital inclusion for people in social housing in order that they can learn, engage and have a voice. And we're going to hear about this in more detail shortly from 2 of the practitioners who've been from the Inner East Integrated Health Promotion Partnership who've been involved in this work as the last presentation in the session this morning. The other case study works on, and I mentioned this earlier, is about addressing the norms and creating structures to provide older people with the opportunity and resources to engage and learn. And that's work being done by Opening Doors graduates to extend the University of the Third Age program in the Inner East. As Patricia said earlier, there are other concepts that interact with social inclusion and other social issues. And some of these are the focus of current policy and action. And working on these can also contribute to increasing social inclusion. So the framework discusses these social issues and their relationship to social inclusion to help promote integration of effort and outcome, so that we're not siloing our work and that the work done in one area can build on the work done in another. So the concepts discussed are social isolation, loneliness, social capital, social cohesion, community connection, and social exclusion. So for anyone working on any of these issues, this framework also demonstrates how the work can be linked and how can all build on promoting social inclusion. The framework is relevant for anyone who's working to enable people to learn, work, engage and have a voice. As well as health promotion practitioners, this includes people whose work contributes to social planning, urban design, policy development, engaging with communities, addressing discrimination, education and teaching in its many forms. In fact, any context in which people are in contact with one another and trying to build that contact. The Inner East PCP will be providing other opportunities for people to discuss application of the framework in your own context. And if you've got any questions, as I mentioned, either in the session today or afterwards, feel free to contact us. The framework will be available from our website, and I think it's also been sent this morning to everyone who's participating today. And you can also contact us via the website. Before I go into questions, an opportunity for questions, I'd just like to acknowledge the assistance that's been given to Amy Whelan and Debbie Wood from MESH, who've worked with us on the development of the design of the framework, and also Debbie, who's worked with me on the development of the animations for this presentation this morning. So what I'm going to do now is I'm just going to stop sharing my screen and invite Patricia to turn her camera and microphone off, and I'm just going to have a look and see what is coming up in the Q&A, and feel free to contribute any questions that you may have in the Q&A section. So
Sue, Sharon Porteous here, just letting you know that there's more of a comment in the Q&A at the moment. The other questions were around sharing the document, which we will post the link shortly, and also the recording for participants, which I've said that we will do as well. Now, there is one question in our chat, so if you'd like to go to the chat for presenters, there's a question there for Patricia. And Patricia,
okay.
Patricia can turn her video and microphone on now.
Okay. I'm just looking at that. Can you just, I can't see that in the chat. Sharon, can you just repost that question?
Sorry, Sue, I've just put it into the general chat.
Oh, okay. Oh, okay.
And there are quite a few questions coming through.
Coming in now. Fantastic, because we have got a bit of time, so that's terrific. So the Eastern Sector Development Team have asked us, does the framework explicitly mention and address intersectionality as an underpinning framework theory, or was it deliberate not to do that? I guess what we've hoped to do by designing it in the way that we have is that to recognise that there's a lot of other theoretical frameworks within that this framework will need to relate to, and want to stay open to being able to work in a complementary way. And absolutely the framework does recognise that people don't live single dimension lives, and that there are many factors that work in conjunction with one another in order to bring about that health outcomes and the experiences that people have. And that we want to look particularly at addressing those many, supporting people's work that addresses those many dimensions. I guess we were mindful of how much theory and how big and how small to make it. So we would hope that it would be supportive of the thinking that underpins intersectionality, and that people would be able to see the overlap. So I'm just having a look back in the Q&A. Someone else, I'm just going to see if there's any particular questions that relate to the to Patricia, because as I said earlier, the ones that are more specific about the framework, that we can put them in a response to the groups. Question for Patricia: what progress do you feel there has been on advancing social inclusion since the inception and disbanding of the Social Inclusion Board?
Well, thank you very much for that question. And I've got to say that my focus has only turned to that recently because of this invitation. In some ways, the closing of the Social Inclusion Board was an unhappy chapter in my life, and I moved on to other things. But I've got to say, when I look at this model particularly, I realise that the Social Inclusion Board, if we look at the figure on the socio-ecological model of health, the Social Inclusion Board probably focused on the top 3 levels of that. Sorry, when I talk about the top 3 levels, that includes the triangle that says social inclusion. And I think knowledge of the impact of norms and practices and structures has developed considerably in the period since then. You know, we were still talking about, as I said before, place-based interventions, which I hope I see progress in that area since then. But, you know, joined up government, those sorts of things that still perceived that the hands of government were the ones that could change things. So I see a greater understanding emerging in relation to the work that different community organisations can do, different institutions, and particularly it was a starting debate in my time at the Social Inclusion Board about racism and factors like that, gender identity and gender, I'm looking for the roles and the understanding of gender and its place in causing disadvantage was much less part of the debate. So I think that the debate on this has deepened, but it's very hard to measure whether inclusion has accelerated in any way. And my great hope is that we will move soon to a measure of well-being that includes exclusion and inclusion. So I do think that people have taken up many of the ideas and developed them considerably since the work of the Social Inclusion Board. I hope that answers your question.
And there's another question here that's to both of us, which is about, so I'll give you a moment. I'll answer first and then invite your contribution, Patricia. Sue and Patricia, where do you see the possibilities for leveraging policy thinking on social inclusion at the state and the federal level? And I've got to say that, and someone else has also asked a question in the context of what we've learned this year in relation to the pandemic, our experience of the coronavirus, which has revealed deficits in social structures and emphasised who in our community were more excluded. And it also triggered an incredible, so I'm reading from this question and part of the question now, it also triggered an incredible community response to support and build inclusiveness. So could you comment on what society or government most needs to address? So I think in thinking about the leverage question, I think the experience of the current year has given us the opportunity to address some of the issues that highlighted inequalities and exclusion in our community. And I think that we need to act promptly and quickly to make the most of that opportunity, while the focus is still very much on COVID experience and COVID recovery. And I guess my sense would be to make sure that that not only happens at the individual level and that all our public health resource doesn't get directed into rolling out and managing vaccine programs and vaccination. I'm not saying that that's not an important part of the response and recovery, but that we do address some of the social issues and connectedness issues that became evident in this time. And I think we've already started to look and it's been certainly an opportunity for building conversation around social housing and the nature of housing, and we've already seen some responses to that. So I think that particularly at the moment is a particular lever that it's important we make the most of.
So, Sue, I'd like to add to that. Clearly, COVID has pointed up the strong connection between crowded housing and different types of housing, and the difficulties in preventing the spread and transmission of disease. So certainly we got active earlier in the COVID period to try and talk to the government about gradually replacing high-rise towers for public housing. And because it seemed like a prime opportunity to say, well, clearly there's a relationship between the structure of housing and disease progression, but at the same time there's need for stimulus in the economy, and so some sort of replacement of the most difficult housing situations might be good. We were sort of fobbed off a little on that, particularly on the scale of the idea of replacing the towers. And we have seen a response from the Victorian government on that issue, where there is a larger investment at this time in social housing. I think the other thing that it showed up so completely is the inequity in the distribution of digital resources and the number of families that had trouble with. My own daughter has 3 children, and the need for sort of 5 tablets in the home, and that sort of amount of internet capacity and all of those. So I think that's one that's a bit easier for government to address over time. I'm not sure, I haven't actually seen the question, so I'm not sure if I'm answering the question completely, but I think it is a time where we do need to fight for resources. Fighting for social inclusion resources still suffers the same problem of the concept and how many ways you can come into social inclusion, and so there's no clear way of making an argument primarily for social inclusion. So I think governments find it very difficult to deal with, in the same way as governments find it difficult to deal with joining up resources and the cost of that joining up, which I've always called glue. So the meetings that are required to work in partnership are never properly funded. The relationships that you have to build are never properly funded. We're still really about episodic funding in government. Sorry, I'll stop there and try and find some of the other questions.
No, I think it really does highlight a challenge in the area. And one of the strengths, but one of the challenges is because the work can happen over such diverse workforces and sectors is a strength, but it also provides some vulnerability in terms of accountability, the measurement that you spoke about earlier that's so important, how people's language can be shared so it's understood that people are working towards the same thing. And I think, it was interesting for me to hear you say in your opening, Patricia, too, that the notion of social factors influencing health outcomes was still taking a while to be understood in 2002 and beyond, and maybe we're still experiencing that when it's become from, well, so what was that, nearly 4 20 years after Ottawa Charter and Declaration of Alma Ata and all the public health, World Health Organization level discussion of the importance of the social determinants of health and that health is socially determined, fundamentally in the language in the public health arena to not easily being translated into the general understanding of health and how that's still work that needs to continue on. So I think so we've got a question here about a structural issue to do with the lack of funding and focus on prevention within the relevant government departments. And I do think that that is an ongoing structural issue. And I also think, which has been identified in recent times too for a range of different arenas, that short-term funding and the vulnerability that makes to people being able to identify outcomes and to understand what differences have been made in the context of their initiative, and to therefore be able to reflect on that and learn from that and share that, is one of the many challenges of the way we do fund much of this work at the moment.
And I see a question from, or a comment from Bronwyn, I think it is, or Bron, that, you know, the government needs to actually understand more than its own political priorities, and there's the potential for community action in that. And the idea behind getting better measurement of social inclusion was that eventually we would have something that showed us that it was getting worse, inequity was getting worse, that people were being further excluded. And that's why we took up measurement in the first place, when we thought we'd have a longer life. But there is no doubt that we need to find ways of bringing community opinion into the debate about political priorities, and to show the harm that is caused by exclusion. You know, there's been so much literature. Unfortunately, I'll have to say, having been in government, policy is not evidence-based. It is largely based on, and more often these days than in my time, I'm getting to be one of those people that says it was better in my time. But, you know, the 24-hour news cycle has meant that it is much more opinion that drives policy interventions than it is evidence. And that's a very difficult thing. I mentioned that I chair Jesuit Social Services. There was a time when we could go to government and say to them, please don't build this prison, and they would listen to us. There is now much more an attitude of, we will listen to people who are frightened of young people and we will build a prison, rather than looking at the evidence. It is looking at public opinion. So it's a very, very difficult debate, and it is the key to unlocking funding, is to work out how you get the community to demand these things, as opposed to just presenting evidence.
So two dimensions to the work, that the evidence isn't necessarily the only element of persuasion, and that has become apparent in all sorts of arenas here. I can see that there's still some more questions in the chat, but I'm going to move on. We've got some questions about the role of philanthropists. Do you want to just...
Look, I can say one thing on...
Have a reflection on that. Yeah, that might be useful for your perspective on that, Patricia, before we just move on.
So it's philanthropists and it's business. So one of the things that was mentioned in my CV was the fact that I have taken on a job being chairing an advisory committee to the CEO of the Commonwealth Bank. And a lot of my friends sort of turn their nose up at it a bit and are quite worried about it, because they see banks as bad places and with terrible reputations. And the very reason I'm there is, post the Royal Commission into banks, the bank is seeking to improve its reputation by doing more responsible work. I will say that corporations are a place that you actually can get funding from. So I have seen the best family violence interventions that I've seen over my career, basically coming from the Commonwealth Bank. And I'm not trying to push them, but I'm just saying that we need to look wider. You need to find strange allies. I did a study tour on juvenile justice in America, and they've improved their incarceration of young people enormously. That is limiting the numbers because of a strange alliance between the religious right, the fiscal conservatives, and the left-wing think tanks. So you've got to look for strange allies in some ways to move the debate. The old techniques of evidence and advocacy are not working very well. And philanthropy, if I talk about philanthropy, it's very important. We've just been given at JSS $1 million to open up a centre for place-based learning, basically. So philanthropy is good. They often want to direct your work based on their opinion rather than their evidence. But there are lots of, as I said, unusual allies, and going back to the well of government doesn't work as well as it used to.
And so in doing that work, can you have the two-way influence there as well? So partnering with them can also help to shift their opinion?
It does, and they sometimes can become advocates for what the evidence shows. They're a way of sort of shifting public opinion as well. So you don't, it's another voice from the, oh, well, we know what those people from social health think. So you kind of, your voice gets silenced because people think you know what you're going to say. But if a social health comment comes from the Commonwealth Bank, for example, then it's not so expected and so can get greater airtime. Yeah, just the action sometimes gets greater airtime too. Okay, clearly this is a conversation that's got a lot of interest, and we'd like to extend, you know, there's great capacity for thinking about how we can continue to extend this discussion. But I'm going to move on now to our final case study. So I'll ask Lou and Alex to turn their cameras and microphones off, and we'll see Patricia again right at the end for the launch. And so welcome Lou and Alex, two of the practitioners. So Lou from Link Health and Community and Alex from Carrington Health. And they're going to present one of the case studies which I just briefly mentioned earlier, which is included in the framework and has been developed in parallel with the conversations in the development of the framework, as the organisations are key partners in the Integrated Health Promotion Partnership. So I'll hand over to you two now, and thank you for being part of it.
Thanks, Sue. I'll just
Thanks so much, Sue.
Our presentation. Hopefully that's appeared.
Well, thanks for the opportunity to share part of our story. In 2017, our 3 community health services, Access in Birundara, Link in Monash, and Carrington Health in Whitehorse, got agreement from DHHS to partner together on a shared priority of social inclusion. The Una East PCP is the backbone organisation of the partnership, providing admin support, resources and training. We have developed and submitted joint health motion plans to the department during the 4-year period through to 2021. As each community health service was already working with social housing communities in their particular municipalities, we included an objective in the plan with shared actions in the social housing setting. And as well described previously by Tracey in her introduction and by Patricia, our definition and understanding of social inclusion has been guided by the report produced in 2016 by Deakin Uni for MSIC, a definition that they'd adopted from the Australian Social Inclusion Board, and that is having the resources, opportunities and capabilities to learn, work, engage and have a voice. Amongst its findings, the report linked social inclusion to the livability of the neighbourhood. The report noted that livability refers to the degree to which communities are safe, attractive, environmentally stable, socially cohesive, and socially inclusive. We chose several livability domains to use in analysing the livability of these social housing areas. These domains included employment, the food environment, especially those shops within walking distance of the estate, such as the milk bar pictured here, housing, public open space such as parks, playgrounds and sports fields, public transport, walkability of the area, and social infrastructure, including local services, leisure and cultural opportunities. Indicators of social exclusion include low neighbourhood quality, low satisfaction with the neighbourhood, infrequent social activity, and feeling unsafe, highlighting possible areas for change.
So we wanted to engage with social housing communities in order to better understand their experiences of the livability of their neighbourhoods and to understand how that influence their resources, opportunities and capabilities to work, learn, engage and have a voice. So health promotion practitioners from each of the 3 community health services mentioned came together to form a working group, and we developed a shared methodology for consultation across 3 social housing communities in Ashburton, in the city of Boroondara, Ashford Chadstone in the city of Monash, and Waddle Hill Burwood in the city of Whitehorse. This process was supported by EPCP and by Bernie Murphy from Deakin Uni. And partway through the process, another housing estate in Hawthorne East, also in Boroondara, was added to the project. So the purpose of the engagement strategy was to provide each community the opportunity to understand the links between livability and social inclusion, and to be empowered to influence the improvement of the livability of their neighbourhoods. And our objectives included to engage a diverse range of voices from these communities using methodologies appropriate for each community, to engage a diversity of other key informants. So for us, that was local government, community agencies, schools, different local movers and shakers, and to identify opportunities for action in collaboration with communities. So our hope was that the consultation process itself and the actions arising would promote social inclusion by creating opportunities for residents to have an influence in decisions that would affect them, or giving them the opportunity to have a voice. So each of the practitioners had an existing relationship with the communities that we were working with. So this meant that we were able to design methodologies that were appropriate to engage with each community. We engaged with residents and stakeholders through face-to-face interviews, written surveys and focus groups in a variety of different settings, locations and times. We asked questions to try and understand what people felt the strengths of their neighbourhoods were and what some of the challenges were to living there. And then we sought ideas and suggestions for improvements people would like to see, or changes that could improve livability of where they lived. And once we had analysed that initial data, we undertook some follow-up engagement to understand the community's priorities out of all of the different issues and ideas that had been raised.
Several common themes affecting livability were identified across the 4 social housing areas. One issue was with graffiti or unattractive streetscapes. For example, hard rubbish left out on nature strips for long periods of time makes people feel unsafe in their community and contributes to stigma. They mentioned issues with traffic and parking, such as residents unable to safely move around their community on foot. Poor connection to local services, which can be for reasons such as hard to physically access, lack of knowledge of service system, financial barriers to services, or feeling excluded. Public transport's not accessible for all. An example here is the lack of low-floor trams on some routes, which excludes people with compromised mobility or those with a pram. Issues with housing and antisocial behaviour also came up, such as housing being too small for the number of tenants. And one of the families told me that there were 4 of them in a 2-bedroom house and they were using the carport as a storage space. And digital exclusion is a big one. While many of us have access to multiple digital devices, some residents just have a phone and often run out of phone credit for calls or data. A young mum, a single parent, told me she uses free Wi-Fi in the Box Hill food court and uses computers in public libraries to search for jobs, etc. Of course, there was no access to these spaces during the many months of lockdown. We've developed rich pictures for both the Ashford, Chadstone and Waddle Hill areas. We use them to visually represent the findings, including the geography and infrastructure of each local area and what the residents told us about living there, linking their thoughts to the various livability domains. We've used the rich pictures as a tool for further engagement with the community, as well as advocacy with stakeholders. Here are a couple of examples of actions addressing barriers to inclusion. Firstly, Waddle Park, which is next door to the Waddle Hill housing estate. The Waddle Hill residents identified the park as really important to their well-being, but reported issues that made it difficult or unsafe to walk there and made it hard to use it for social connection. During the COVID lockdown period, Parks Victoria commenced a community consultation on a $4.3 million upgrade of the park. Carrington Health has been able to build a relationship with Parks Victoria and worked with them to ensure Waddle Hill residents' views and ideas were heard as part of the consultation. We will do the same with further phases of consultation in 2021. Secondly, the Ashford Chadstone consultation highlighted a high level of community concern about pedestrian access over a busy road in Ashwood and a strong desire for this to be addressed. These findings were communicated to Monash Council through various avenues, and the concern was acknowledged by them. We were pleased to learn that pedestrian crossing has been included at the intersection in recently updated plans for development in this area. Back to you, Lou.
Thanks, Alex. One issue that was common across all the communities was the need for improved digital inclusion. COVID-19 has, amongst other things this year, reinforced the critical importance of people being digitally included, and it's exacerbated existing inequalities in this space. So our 3 community health services, along with Inner East PCP, are working together to build partnerships and explore opportunities to address the norms, structures and practices that have compromised digital inclusion for people living in social housing. And when we talk about digital inclusion, there are 3 pillars that we look to address, which are around access, affordability, and people's individual digital capability. So far, we have had some initial scoping meetings with the network of Inner East community houses to learn about their Be Connected digital mentoring program, and to consider how we might support providers of this program to engage with social housing communities and make sure that the program's reaching people who are most at risk of exclusion. And we're also exploring some advocacy efforts to which we can add our voices and the voices of our communities to be addressing some of those broader issues around infrastructure, access and affordability. As Sue mentioned, because the framework was developed by the PCP in parallel to this work, it wasn't available for us to use as a guiding document. However, some of our experiences and learnings from this engagement piece have informed elements of the framework, and our engagement methodology has demonstrated the principles embedded in the framework. So, for example, using the socio-ecological model of health as a way of understanding social inclusion, a commitment to addressing the norms, structures, and practices that privilege some groups over others, and the importance of working in partnership. So thanks so much. We've been Alex and Louisa from Carrington Health and LinkHC and Community, and we'd like to acknowledge our colleagues at Access Health and Community, Owen Peach, Angela Vidic, and Heather Cole. Thanks everyone for coming along today. Thanks, Patricia. It was so wonderful to hear you speak and to understand a little bit more about the history and the context of what's occurred and paved the way for some of this work that we're doing now. And huge thanks to Inner East PCP for their support of all of this work and for the opportunity to come along today and share a little bit of what we've been doing.
Mic as well as camera, Sue. Thanks very much, Lou and Alex, for that presentation and for being part of it. And I'm sure if we get questions in the Q&A for you as well, people might like to know a little bit more about your project, so we'll be able to field them as well. I see we're getting some further comments in the Q&A, so please feel free to keep them coming, but we haven't got any further question time at the moment. If we feel that we need to generate a forum to have some further discussion, that might be something that will come out of today's session. But now what it gives me great pleasure is to invite Patricia back to officially launch the framework. As Tracey and I both kind of reflected earlier, we were delighted that Patricia could join us today in recognition of the work done by the Australian Social Inclusion Board, and as a reminder of the importance of honouring those whose work has gone before us and whose contributions we build on, and in how that enhances all our efforts on behalf of the community, as we realise that good work can continue on even when we work in partnership, and when we recognise that even when maybe the entities themselves are no longer around. And I guess to note that that is something that is on the mind in PCP land as well at the moment. So if you would like to say anything as we launch, and I'm going to also share the screen. So yes, if you've any words you might like to say.
Yeah, well, it's my really great honour to launch formally the Inner East PCP Social Inclusion Framework. In doing so, I congratulate all those involved in its creation and to the deepening of the understanding of social inclusion. I formally launch it.
Hey, sort of, this is a bit weird, so take that there up. Okay, ribbon, it's been cut. Woohoo! So thanks to everyone who joined us today. I don't know, Tracey, would you like to come back in and say anything else before we... This is the other thing I find strange in these forums, that we're not all going out and having a cup of tea and mingling now. But it's been great to know and to see a presence of people here while we've been sharing this with you today, and I thank you for your participation and everyone's comments. And as ever, these pieces of work are always, we hope, dynamic, so some things, you know, launch out and hope can be built on, and even if that doesn't end up being something that happens in PCP land. So yeah. Anything else you'd like just to reflect on, Tracey, before we do this funny way of saying goodbye in these events?
Yeah, look, I'd like to just say how very proud I feel, and you know, I feel emotional because, you know, the work that we're all doing, you know, Patricia in her role, you know, all of us at the PCP, the practitioners that we work with, their managers and all of that sort of thing. are all, you know, the department, we're really incredibly dedicated people, and, you know, committed to making a difference to the lives of people, you know, to all people really. And, you know, health equity is such an important principle behind what we do to make sure that that is available to everybody. So this is, you know, I think a really, really important piece of work. It was a gap. I'm really, really looking forward to rolling it out and working with our partners, and even more broadly than our region, making it available to inform practice. And yeah, I'd just like to thank everybody involved, because it really was a collaborative effort. So thank you. Thank you to everybody. And thanks, Patricia, again.
Okay. Thank you all.
Thank you.